Can you just put one slide?
No, no. I will be starting for introduction of Geo webinar, and then Raju will take over. You will get the slide, no problem. Now it is already. I was click for the streaming. So first, let me complete this process so that we do not get disturbed. Yeah. Yeah, I will put. I will put. Just wait.
I do have some cases also. If you know.
Yeah, if time permits, we can always. Yes, we can always.
Sure.
Just 1 minute, sir. I've done. Okay. Can you hear me, everybody?
Yes.
Please. Yes. So I am starting the introduction. So let me start. Anybody is moving somewhere? Is there somebody is printing somewhere? Printing noise is there. Printer noise.
Nobody's.
Is anybody has joined or unofficially? I don't know. Okay. So, dear audience, all the delegates and the faculty, we at the Gujarat Orthopedic Association welcomes you for Gujarat Orthopedic Webinar 4, special foot and ankle webinar. And we are very much thankful to Dr. Raju Shah for bringing this webinar in a present form with the foreign faculty and renowned orthopedic surgeon from Chandigarh, Dr. Mandeep Dillon and Dr. Nimish Patel. And just I want to give you an outline how we'll be doing. This is the website which we are seeing, and here you will be able to see that video exactly here. You can see the video here, and then if you want to ask the question, we have put a Slido here. You can see Slido here. You can type the question here. Type the question. It will reach to us, or you can record your audio or video on a WhatsApp and just click here to WhatsApp me. It will come to me, myself, Dr. Navin Thakkar, and form of Geo Webinar 4. We get feedback from all the corners and we improvise gradually whatever we can do. So please do not forget to fill this feedback form. So now Rajiv bhai, take over it. I am stopping the sharing. You start the sharing.
Yeah. Good evening.
Very good evening.
And welcome to all the faculties and delegates. This is because of the enthusiastic president of Gujarat Orthopedic Association that we have been fortunate to have this webinars. And let me tell you that these webinars are being live attended by more than 4,000 orthopedic surgeons all across the world, because the link goes to more than 29,000 orthopedic surgeons all across the country and outside the country. So thank you very much, Dr. Navin Thakkar, for this enthusiastic step which you have taken. And
Thank you, sir. Thank you, sir.
let me introduce my esteemed panel. Professor Vinod Panjbavi is from Texas. He is not a new face to India. He has been a mentor to all of us in India. His innovative teachings are very well known, and sir has done phenomenal work into minimally invasive surgery, less frank fixation, and all the time he has been our mentor. Welcome, sir. We have Dr. Mark Davis, a very good friend and a very great humanitarian person. I have been learning a lot from him. He was here at Baroda in 2018 IFASCON, and as Dr. Navin mentioned, he just recovered from the corona crisis. Welcome, Mark. We have Professor Dr. Mandip Dillon. He does not need any introduction. He is also one of my key mentors, and he has done phenomenal work into this country. The flame of the foot and ankle has been ignited by him. Welcome, sir. And Dr. Nimish Patel is a young and dynamic professor of orthopedics at Government Medical College in Ahmedabad. Welcome, Nimish bhai. So let's start ball rolling with the case presentation. I am going to put forward a case and going to ask panel's opinion about the case which is being presented. A 21 years old male had a fall and a closed injury, and this was the X-ray. And he was given a plaster, and this was 10th day in a plaster, and this with this X-ray he comes to us. So uh, let's start with Professor Panjbavi. Would you have given a plaster, or would you have done something else into this fracture of lateral malleolus?
So thank you, Rajiv, and thank you, Naveen, for putting this show together. Basically, one thing I've learned over the years that you should never take any of these fractures lightly. Sometimes they look very benign, and they may be benign, but what we have to assess is whether they are stable or unstable. So, it's hard to see if there's something going on in the posterior malleolus, but obviously we have to do a clinical examination to see, how much of the tenderness is there or swelling is there, the mechanism of injury. So the higher energy forces will not only disrupt the bone, but also the soft tissues. So if there is additional soft tissue instability is suspected, then I will do a stress test to see if there is opening on the medial side. Otherwise, the fracture in the lateral malleus itself doesn't appear to be too bad. So if there's no instability, then certainly it can be treated, no soft tissue instability, then certainly it can be treated in a cast. But, you have to monitor that throughout the period so that there is no, radiological or clinical signs of instability. So I think, it can be managed in a cast, but I would like to make sure that there is nothing else going on.
Dr. Davis, would you be taking some special examination on hand over and above stress views?
Well, I agree with Vinod. On the initial X-rays, there it looks an essentially very stable fracture. What seems to have occurred as it has been put into a plaster is that there seems to be an element of external rotation that probably has been dialed into the application of the plaster of Paris. And if that could be corrected, so I would change the plaster, I would then see if we could re-establish effectively the same position as the original X-rays. Now, I don't have access to stress view x-rays in the National Health Service, so I don't find that particularly helpful. But one way you can do a stress x-ray is effectively to ask the patient to do a standing x-ray. That isn't such a mad thing to do, because quite a few patients will have tried to walk on this as they've made their way to the hospital, and it may be days later that you actually see them. So there are things in the history that can give you clues to as to whether the ankle is stable or unstable. So I think a weight-bearing X-ray isn't a bad way of dealing with things, and that would be something that we would do in our hospital.
Professor Dillon,
Yes.
would you be taking some specialized stress view for such a case? And
Uh,
how do you take it?
Rajiv, if you could just put on your screen the X-ray, AP X-ray, which Mark was talking about. Now, if you look at it in comparison to the pre-op or pre-plaster X-ray, what is happening here is that at the time of application, very rightly stated by Mark, there has been some degree of increase in external rotation, which itself means that just in the act of applying a plaster, we have sort of unmasked an instability, even which is seen also on the medial side, which is probably also seen in the incongruency of the of the ankle joint as compared to the pre-op X-ray. So this is unstable. So if we want to treat it by non-operative methods, which is not the worst thing in the world, then we must put the plaster in some degree of neutral or internal rotation, which was correctly pointed out by Mark. However, he's 21 years old and he's a young adult, and we have been able to unmask some instability by the act of see the patient. So it borders more towards maybe I do a stress view. I can put him on the side and see if it becomes even worse after cutting the plaster, the so-called external rotation stress view. And then you can sort of, I would also go in and evaluate clinically for his medial side. If there is significant tenderness, or if you see a ecchymosis like you are showing over here, that means the medial injury is unstable. So I like to say repeatedly, I would like to reconstruct the whole ring of the ankle, make it stable, and possibly allow early range of motion, which may or may not involve some degree of weight bearing.
So, Dr. Nimish, would you be taking some other stress view for this patient? Standing plus something else? I think we have lost.
Can I answer? Can I answer, sir?
Yeah.
Yeah. The instability is not being taken care by static views. So we have some dynamic view. That dynamic view we get with the gravity X-ray.
How do we get it?
Gravity
Yeah.
X-ray. We have to put a pillow, and then the other part is dangling of the foot part, and then you can see by gravity it get displaced, and you can see how it get displaced.
So,
So
yeah, go ahead,
And
please.
that's a good point, actually. We do that in our clinic. Mark also raised a good point. You see, if a patient with this kind of fracture is walking around, that raises a red flag. And that red flag is neuropathy. You know, even in young patients, sometimes you could be fooled, and for thinking that it is a stable fracture, the patient is walking around, but it is sometimes because of neuropathy, and sometimes you'll be surprised that they have type 1 diabetes. And then, if you don't ask that history or confirm that they have a normal sensation, I think we may
Yeah.
have a problem.
So great point made. Gravity stress view is taken with the patient's foot into the complete external rotation position. The patient is brought to the edge of the table like this, and this is how a gravity stress view would look. This is an example, but this is how, if an unstable lateral malleolus fracture is there, the gravity stress view is going to open it, the thing in on the medial side. And that's why if we go back to our case, this is how this fracture after removal of the plaster on gravity stress view, this displaced and a medial clear space open. Dr. Nimish, are you with us? Okay.
Can I make a point here?
Yeah, please, sir.
Rajiv, I think one of the things which we teach to all our students and all people when we discuss it is we must not take all our decisions based only on the x-rays. Even before we take these x-rays, we must have examined this patient. And I think both Vinod and Mark brought out two very important points. Vinod's point that there could be an element of neuropathy if he's walking is very relevant. So we have to ask him how much is the pain, how much is the swelling, how long have you been walking on it, which will answer that question. And secondly, we must examine the medial side for tenderness and for this, and then correlate it with the x-ray findings. Let's not just focus only on the x-ray to take our decisions. Actually, what Mark said was that when you have put the plaster, you already put it in into external rotation, which is a stress view in itself. So this was unstable when you saw the x-ray in the plaster.
Can I ask one question, Rajiv bhai?
Please.
Is there anywhere a practice to see in such suspected cases to give a short sedation or anesthesia and check under ATV in different positions to check the instability?
No, if you are not sure about whether the fracture is stable or unstable, you can give a plaster to the patient, ask patient to walk with the plaster, call patient after about week or 10 days, and again recheck whether the fracture is displaced. That is one another method. And then if it is displaced, you may have to go in and do the intervention. But the best thing which faculties have brought out, point number one is the medial examination, clinical examination. Point number two is checking for the neuropathy. And then point number three is making sure whether it is stable or unstable. So moving forward with this case, this is how this patient was.
Sir. Before that, there are 2 or 3 questions came online.
Please.
Somebody is asking the plaster was given below knee or above knee, and
This was
whether does it make any difference?
Can I ask Professor Panchbhavi to answer this question? Patient was given a below knee plaster.
I can't remember when was the last time I actually put any patient with above knee cast, even for Achilles tendon. We used to do a lot of above knee cast, but I don't think so. I think, it does not make a difference. We have to, like Dr. Dhilan mentioned, we have to restore the stability and make sure that we have a congruous ankle. Whatever method you do, you have to maintain the congruity. So from day one to the end of the healing, whether it's bone or ligament, we have to maintain the congruity.
Dr. Vinod, there is a question of stress view. You mentioned that stress view. How often you do stress view, and how do you manage the pain during the stress view? Is it feasible to do with the pain?
That is a great question
from Dr. Gaurav.
Dr. Gaurav, thank you for asking. That's a great question. Again, it comes to the clinical decision making. If there's a soft tissue disruption, if you see a patient with extensive ecchymosis, swelling, and the mechanism tells you it's a high, I would say, there are clear-cut areas wherein there's a lot of ecchymosis, a lot of swelling, and you could virtually think that it is unstable, and you could still do it if you wanted to. And it's not too bad, actually. Patients can, like Dr. Rajiv Shah showed, that they can tolerate it very well. We actually have compared that with intraoperative stress view, and we published that paper in one of the journals, which show that pre-op examination can reveal some instability. If there is one.
Yes.
Can I take this forward, Vinod?
Yes, sir. No, yes, sir. Can I
Because
add a
what
question,
I'm trying
sir?
to say, Navin, will answer to some extent both the questions.
Okay.
The above knee cast is not required because once the fibula detaches from the proximal fibula, lateral malleolus, the rest of the interosseous membrane is stable. So there is no need for very high casts in these kind of fractures. Secondly, even stress view without anesthesia, if you cannot demonstrate instability or you are in doubt, that means it is not that unstable. Because despite the fact that these guys have a bit of spasm, they have a pain, if you put them in the position, lateral position, pillow underneath, like Rajiv showed all these slides, they will move. If they are not moving in this position, then it's fine. You could probably apply a below a knee plaster. And this is a Weber B going on to C kind of a scenario. And these will do well. And you got enough evidence out of Australia from the crossback trials, etc., that they do well. I
Yes,
was
sir.
only bringing into the fact that this was a young adult, and even in by applying a plaster, we could see the degree of Taylor shift and rotation of the fibula. That's why it makes it significantly unstable.
Yes,
Yeah.
yes, sir. But the
Now the
follow-up
next
question, follow-up question, sir,
Hmm.
from President of Foot and Ankle Association of India, Dr. Rajiv Vora.
Yeah.
Does when you are in doubt, does MRI has any role in assessing the extent of the deltoideal
Yeah.
and can influence the management?
Let Mark Davis, let Mark answer this question. Mark, do you have, I mean, do you think of going for MRI in such cases?
I don't think so. It's an expensive resource, and at the end of the day, we have to rely on our clinical skills here. And we've heard very eloquently that it's about assessing the medial structures, looking for the clinical signs, ecchymosis, tenderness, etc. And I think that you can gain all of the evidence you require by getting your foot plantigrade in a good below the knee cast, relaxing the Achilles tendon, making sure that the mortise is restored by having the foot plantigrade in the plaster. I don't think an MR adds anything to this at all, and it's an expense that we don't need to be spending.
So let's move forward. And
Yes.
then this patient was operated in with this kind of fixation. A tightrope was fixed and the fibular fixation was done. Nimish bhai, any comments onto this fixation? Would this fixation stay or fall apart? We're not able to listen to him, Navin bhai.
Yeah. Nimish bhai, I think we have lost him. Nimish bhai, he's there. Please speak.
We are not able to listen to him.
Yes, it. Hello. His connection is lost.
Okay.
I
So,
still see some medial incongruity. I like an opposite leg X-ray to compare.
okay. So that is what was the question. And this is 6 weeks post-op.
I think I think the fixation of the tightrope is very near to the fracture. That
Uh, if
that
it would
may be
have
the
been, if
reason.
it would have been lower, it would have been through the fracture.
Through the fracture.
Yes,
Side.
through the fracture,
So,
right? But it is
yeah.
very near. Yeah.
So, Professor Vinod Panchbhavi, your opinion on to this fixation? This is 6 weeks. Patient is mobilized, non-weight bearing. Heavy.
Yes, unmute yourself, please. I am unmuting. Sir.
Yes,
Okay.
I apologize.
Please.
Yes.
Yeah.
I just realized that I muted myself. My
Yeah,
kids
yeah.
are waking up, you see, so I don't want to.
No problem. I'm seeing everything, so don't worry.
Okay, wonderful.
I will manage.
So going back, so you see, I mean, there are a few things here. You see, I don't think we got the length. Looking at it, I don't like the contoured plates for one reason, because they kind of pull the fibula away, distal to the fracture. They pull the fibula away. If at all you need to use a contour plate, I actually straighten it up. I under contour it so that I can push. After I get the fixation, I can get that talus in and shift it medially to sit it nicely in the medial corner. So that's one thing I do. Obviously, you need to make sure that you got a length out, which I don't think there is. This particular screw is actually intra joint, I think, appears to be at least. The other thing is the placement of the syndesmosis screw, I don't like it. So if you look at the other x-rays, my syndesmosis fixation is much closer to the joint than what we see on the radiographs here. So, in all, I don't, and also these, I also want to make sure after I fix this, whether I have achieved the medial stability or not. You see, so if that hasn't occurred, then, I do open deltoid ligament repair I've seen quite a few cases where this was missed. I have examples of those cases. If time permits, I can, with Dr. Rajiv's permission, I can show those cases with you all. But this is increasingly becoming very apparent unless you provide a lot of stability on the medial side. Sometimes indirectly you can achieve this, but sometimes even after you do the syndesmosis, if you do not test the medial stability, there is a possibility that this medial stability will not be achieved in long term, and then you have medial ankle instability left with the patient.
So thank you very much.
Yes. Follow-up question is that to Dr. Vinod, how do you check intraoperative medial instability?
Okay, so it's a great
Because that is
question.
the question from the audience that you said that medial instability, then explore the deltoid and repair it if it is there. But
Yes, yes.
how to check it?
Again, you see, so, before you start off these cases, is sometimes, Dr. Rajesh Shah's case is really, really interesting because it looks on the face very simple, very benign. And you would be tempted to just treat it conservatively. But, sometimes if you do not assess the medial instability, if the medial space is opened up intraoperatively, you can assess, you see how much unstable the soft tissues are. The more unstable the soft tissues are, the more it behoves on you to provide that stability. Whether it is suture anchor, whether it is very careful casting and following up at weekly intervals, whatever you do, you have to maintain that medial gutter. The medial gutter should be congruent throughout the ankle mortise. The tip of the medial malleus should not be away from the talus. So if that is not achieved and not maintained throughout the healing period, you have a lax deltoid. You see, and increasingly we are finding out that it's not enough sometimes just to put a plate and even syndesmotic fixation. So in clear-cut scenarios wherein there's a complete deltoid disruption, it is more important to go ahead and then do some kind of stability procedure there, or at least maintain that medial congruity. Now, in doubtful cases, that's when you actually do an intraoperative evaluation. And how do you do that? You can put the fibular plate, and then if there is syndesmosis disruption, you stabilize the syndesmosis, whether it is with syndesmotic screws or whether it is a posterior malleolar fixation or anterior, anterolateral fragment fixation. You need to stabilize the syndesmosis and then assess the medial ankle instability. So you can actually open it up. You can do external rotation. You can do a valgus stress at the ankle and see how much it's opening up. And you can also do the reverse and see if your internal rotation or abduction of the ankle keeps it in place. So if we can reduce that and hold it reduced, that means you are using a cast in a serial way, like at weekly intervals, you need to check. Because if you check the patient at 2 weeks and then don't check the patient until the next appointment, it will be 4 weeks further or 6 weeks from the day of surgery, you'll sometimes find that the medial gap has opened and the deltoid ligament has probably not healed. The alternative to that is if you are able to open up the medial gutter, even after you did the plating of the fibula and syndesmosis fixation, then the alternative is to do a suture anchor fixation.
So that brings to a very a very controversial point, and I would like to take opinion of every panelist. Mark, when do you operate? My question to every panelist is, when do you open the medial side and do the deltoid reconstructive surgery in an ankle fracture case? Question to Mark, followed by question to Professor Dillon and question to Professor Nivesh Bhai.
Thank you, Rajiv. Yes. With the x-rays that are currently on the screen, they're very interesting. As this stands, this ankle has been x-rayed with the ankle in full plantar flexion. That means that the posterior medial to lateral distance of the talus is narrow, and that's what's being shown in the x-ray. So it's giving the appearances here of the medial side being open. That would be my first comment here. So To answer the question directly, I think it's important with this case to absolutely anatomically reduce and fix the fibula. So a good lag screw and a plate that doesn't contort the fibula out of its reduced position. If when you have done that and you are using your image intensifier, you feel that there is a block to that reduction of the talus sitting against the medial malleolus with the foot at 90 degrees to the ankle, then it may very well be that the deltoid is in the joint, and that would be an absolute indication to go in and explore it. If, however, you are having restored the length of the fibula perfectly and have anatomic reduction, then this is a supination external rotation injury using the Lauger-Hansen classification, and therefore the intraoperative screening of this patient should be to put the patient through a supination external rotation assessment of their medial side and their syndesmosis. I would be surprised if this patient had a syndesmotic injury, because actually the interosseous membrane has remained intact throughout all of this, and it is only the anterior inferior tibiofibular ligament that will have been involved with this fracture pattern.
Thank you.
I'll take it further, Mark.
Professor Dillon.
I'll take it further. Now, look, we are addressing not specialist foot and ankle surgeons in this webinar. We are addressing general orthopedic students and postgraduate students. I really don't want them to take home the message that the deltoid has to be addressed every time. This case is unique. In most cases, a vast majority of cases, as Vinod also agreed, we do not need to address the medial instability. However, if we are able to demonstrate that there is medial instability, we should not hesitate to stabilize it. And as Mark also said, which is very unusual, because I do agree, these x-rays are not very good. The lateral view is not lateral enough. It's taken in plantar flexion. So there's got so many things wrong over here. Now this x-ray, which you see over here, although you see a little bit of a nick underneath the lag screw, showing that the fibula may not be fully rotated, but the medial side looks okay. So let's not bring in too much of an overkill for fixing the deltoid primarily. If it is not unstable, as demonstrated, as discussed by my panelists previously, I would leave it. But if it is grossly unstable, as Vinod said, you'll understand by the degree of ease of reduction, the degree of ease of moving it out of there, then you probably could. But still, I would err if I find that it's very well reduced and it's stable to some kind of a gravity stress test. I'm not a routine fixer of the deltoid ligaments.
Dr. Nimesh, are you with us? Please go ahead. Dr. Navin, we are not listening to his audio.
But there is a problem from the source here. We have not made him mute. There is a problem from his source itself.
Can you hear me now?
Yes, we can hear you. Very good.
Okay. So generally in these, I agree with all the previous speakers, but a simple trick that we teach the residents is that you take an X-ray of the opposite side on the C-arm view and keep it stored there. After you have done your surgery, and if the clear spaces of the ankle are not matching up to the other side also, then probably you need to take it to the next level and probably need to go to the medial side. Otherwise, I agree with Dr. Dillon that generally you don't need to address the medial side as long as the clear joint spaces around the talus and the distal tibia are good enough. In your case, probably the tightrope was placed at a too higher level to really snuck down the syndesmosis together. And probably that is the reason why the clear joint space on the medial side has increased even after your fixation. I would have gone a bit lower and probably put a syndesmotic screw, yes, at that level, through the plate, maybe going near the fracture site, but that at that level would have been a better choice than a tightrope more than maybe 4 centimeters above the ankle joint, which is also one of the determinants where you need to place your syndesmotic fixation.
Perfect.
Hello, sir.
Thank you very much.
Raju, still there is a question from Dr. Susrut Babulkar to Dr. Vinod. Despite of all the reconstruction and good stability achieved, how many of the patients still continue to be symptomatic after, say, 6 months? Probably due to deltoid instability, medial instability, or anything else. You want to add something?
That is a great question. And that's why there is increased focus and realization that we probably are not doing enough on the inside of the ankle, you see. So it can fool us, I mean, some people are actually using a syndesmotic fixation as the indirect method of reducing the talus in the ankle modis. Dr. Babulkar is asking a great question.
Yeah.
Because we are increasingly seeing patients coming back with medial ankle pain, with medial instability, going up and down the stairs is problem. Because you see, if there is a severe disruption of the medial side, what can happen is that either the deltoid ligament can retract or get infolded, and you can pretend or you can make sure that the ankle is in the mortise by either adding a syndesmosis screw or getting the length out and maybe cast them in inversion. But if you're not careful and then don't follow it up with weekly interval, because what happens, the leg will, the swelling in the leg of the leg will reduce with time. So you see them at 6 weeks, lo and behold, you will find medial instability. And deltoid ligament, we're increasingly realizing that if we cannot get that talus very close to the tip of the medial malleus and keep it there until it heals, it can heal in a laxed position. And then the game is up. So then the patient will always have some kind of symptoms, which is some kind of symptom of instability. So we need to address the medial side, whether it's not a big deal. People do much more complicated surgery, opening the medial side, at least clearing the deltoid ligament. Even if you don't have suture anchor, there are some methods you can try. But even if you do not open up the medial side, you have to make sure that you see these patients at least at weekly intervals, because as the swelling goes down, the talus can drift. The more unstable, the more disruption is on the medial side, the more instability there is. This happens despite the syndesmotic fixation. I tell you, I've got cases, and I wish I will have some time to show my cases, and this is increasingly being recognized. And hopefully when we try to pay more attention to the medial side, I'm hoping that the number of patients wherein there are poorer outcomes will decrease as well. Great question.
Yeah, we will
One last question.
No,
Then we'll move
I'd
to.
like to add to this answer, because
Okay, fine,
I
fine.
don't want Sushruth and others to take home this message that we need to stabilize the medial side all the time. The message here is understand what is medial instability, be able to diagnose it clinically and on radiology, and keep a close watch on those patients which are potentially unstable. Please don't open them all up on the medial side if you got a good reduction at the time of this. Surely you washed them, but you will notice that these are a small percentage of all the ankles that you treat who have this problem, and then you have to look at it. If you have got intraoperative signs of instability, only then should you address the medial side at the same time.
I think we can go on debating on this issue.
Only last question.
Yeah.
To Dr. Vinod. This is a pointed question to Dr. Vinod. What would you have done deltoid repair in this case? That is the question.
In this particular, again, I go back to clinical evaluation, intraoperative evaluation. It's, I think, more of a judgment call. If this opens up a lot, if I again, this is
The distinction of the question is, some of the faculties saying it's not required, and some of the faculties said that you check it. How to check it?
No. Naveen, you've got it all wrong. If it is
I have not got
unstable,
wrong.
it
These
is
are the
required.
questions.
Yeah,
are coming.
but that is why I'm trying to give a clear message. If it is unstable, it should be done. But first, understand how to pick it up, whether it is unstable or not. If it is unstable, you should do it, because it's like the pelvis. You have to reconstruct the ring from all the sides. You can't leave it from one side. But if it is not unstable, and then you can leave it, and it is reduced well and stabilized from the lateral side with the syndesmosis in a vast majority of the cases. A few cases are left unstable on the medial side. That is what we are discussing, not all ankle fractures.
So the moral is that after you fix everything, check for the medial instability.
Yes.
And keep an eye over it. And initially also your clinical examination should also give a suspicion. Altogether would make your end result successful. Anyway,
Yes.
this was somebody else's cases, Nimish bhai, not my case. Moving forward,
Well,
moving forward
I
to
didn't
this.
say anything.
So moving forward, this was a Franz stoma, closed fracture in a male aged 48 years. And this is how the CT scan was taken at the time of injury. This were some CT scan pictures. And this patient was treated like this. Now, comments from Dr. Nimish onto this fixation.
Well, I don't think it's a good fixation. I won't. I'll be direct, but this is not a good fixation. His
So, what are the
fibula is
problems?
all right. So the fibula is not out to length. I think there's some problem onto the lateral side of the tibia also in the articular region. This needs to be revised actually because there is no lateral support.
Okay. So, shortening of fibula, rotation of fibula, syndesmotic malreduction. Now, my question to every panelist: how do you make sure about precise length restoration of fibula whenever you are operating a comminuted fibula fracture? Question starts from Professor Panchbhavi.
These are very complicated cases. See, so whenever there is a lot of comminution and then you have two different fragments with a lot of comminuted fragments in between, it's very difficult. So basically, it's not just the length, but rotation and in restoring the natural contour of the fibula is really, really critical. You have to be a really good artist, really, a skilled surgeon to restore the anatomy in the sense the length, the rotation, and also the contour. We imagine the fibula is not a straight pipe. It's not a lead pipe. It's not a very straight pipe. It has got nice curves. So we have to make sure that you don't overdo it or underdo it. So this requires great skill, but you have to realize that you have to open up both sides and temporarily fix the medial malleus, and because otherwise if you overdo it on the lateral side, the medial malleus cannot come into place. So it is a skilled surgeon who can get it right. But again, the principles are you have to restore the bony anatomy, the length, rotation, the contours, I say, and then restore the ankle.
Mark? Yeah, sorry. Go ahead, please.
Rajiv,
Mark,
thank
yeah,
you.
your view, how do you take care of this? Any tips to our audience on to precise restoration of the length and rotation of fibula intraoperatively?
Yes.
Can I have a small comment with the mark? Once you start your audio, there is some machine, a printing machine that goes on ahead of the printing, goes there, and that sound comes in the background.
I'm not in anywhere that's got a printer. I'm in a clinic room.
Fine.
So the first thing I'm going to say is that when you have a comminuted side of any articular fracture, whether it be a wrist, an elbow, an ankle, it's always worthwhile fixing the less comminuted side first. So although these pictures are not great, it's very clear that the surgeon has recognized that fixing the medial malleolus is going to help restore some of the length of the fibula. I suspect they've done that first because that actually is reasonably well reduced. Usually then, with ligamentaxis, that tends to help with reduction of the fibula. Rajiv, can I ask you to show me the 3D reconstructions of the CTs, please? So on the, I think this one. So if you have a look on the left-hand view here, you can see that there is part of the plafond which contains the anterior inferior tibiofibular ligament. And that fracture fragment needs to be the next bit that is restored onto the tibia. So it's very much like a telo fracture. And if you were to anatomically reduce that, that would be the next thing that would help you restore fibular length, and it would certainly help you govern how you would control the rotation of your fibula. Thereafter, the fracture is so comminuted that I suspect you will end up having to do bridge plating of the fracture. But I think that those are the two key articular fragments that you need to address.
Professor Dillon, your tips on to restoration of the length and rotation of fibula intraoperatively?
I think it's been beautifully discussed by both Vinod and Mark. One additional thing which we were talking about even in the previous case, which Nimesh also brought out, it's wise to have an AP and lateral X-ray of the opposite foot right there in the OR to be able to get a rough idea. You probably get a very good idea about the fibular length. Now, the key point here is if you look at the fibula, it's attached to that small fragment of the what do you call the distal tibia. Right, yeah. So I think Mark has put it very beautifully. You bring that fragment down, you reduce the medial malleolus, that fragment could probably come out to length. Not exactly, but to a large extent. And then you can fine tune it subsequently. The other issue often is the rotations. It's not only the length, but we often leave them in a little bit of external rotation. So once you've got the fibula out of length, you try and temporarily stabilize it. And then you see for the position of the talus inside the ankle. Because if notice over here, the syndesmotic area is comminuted also. So it's not one piece you put it back here. It's the fibula which is comminuted, gives rise to problems about the length and accuracy of reduction. You've also got the distal lateral tibia anteriorly, if I'm not wrong, comminuted. So it's not the easiest case to do. And I mean, I don't like the reduction done, but I can understand the difficulties the person who did it who had. But if you understand what we are talking about, you'll probably get a 90 to 95% achievement of the reduction.
Dr. Nimish, your view?
Yes. All right. In this case, as Mark has already pointed out, you go with the bone which has the maximum length and which you can put back nicely. So I would have started onto the tibia, the medial malleolus, and the anterior tibiofibular area. So once you go into that anterior tibiofibular area, you can see both the distal tibiofibular joint as well as the joint it makes with the lateral corner of the talus as well as the distal part of the tibia. Now, you don't need to hurry to fix the fibula here first, but what you need to do is to get that joint congruent or that anterolateral corner congruent 100%. So that will take care of your length of the fibula as well as rotation of the fibula. Then the next part comes that whatever in between, as already pointed out, you can do a bridge plate because you have already taken care of the rotation of the fibula as well as the length. You can temporarily stabilize the fibula with two thin K wires, one in so that the fibula stays into the mortise, sorry, not at the mortise, but at the distal tibia fibular joint in its correct length and rotation. And then in between, you can bridge along and then plate a fibula and probably do a syndesmotic fixation also in this case to prevent further valgus.
Hello, Raju bhai.
Yes.
Is there any tip from any faculty? Intraoperatively, what you see is only the picture of IITV. Yes, same,
No,
same,
you
same, same,
need
same,
to
same.
open
Rotation,
there.
yes,
You need
yes,
to
yes.
open the joint
No, no,
there.
no, 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 no. What was the question? That slide has come now. The
Yeah.
shape of the fibula tells you exactly whether it is in the rotation or not, external rotation or interrotation.
And what I do for
Not
such cases
always.
is not always
We,
easy.
yeah.
But what I do for this kind of cases is I paint and drape both the lower limbs.
Yes.
And intraoperatively, I try to compare both the lower limbs, both the ankle in the same degree of rotation with patella and second toe lying into the same line. So, but still, as faculties have commented, it's very, very difficult, more so when you have a communicated situation. Uh, any other point any faculty wants to add? Otherwise, we go on to the next
No, no,
case.
no, no. There are questions coming from the
Please,
audience that
let's go ahead and have the questions, please.
clear it that first to be fixed fibula to get the length and rotation or to fix the tibia first. That is the question they are asking.
Tibia
It is
first in this case. Because you
cannot.
don't know the length of the fibula.
Yeah, Namish is right. You cannot judge the length of the, it's like both bones forearm. Ideally, you have to reduce all of them. The fixing the
right.
medial malleolus makes medial construct stable. And remember here, it's, we talk about a syndesmotic injury as a ligament injury. Here, the anterior ligament seems to be intact because it's taken a large chunk of the bone with it. It's the posterior one which is gone. So you have the great advantage of getting the distal fibula along with that small anterolateral fragment of the fibula, and then you would be able to get the length right. There probably would be some degree of anterolateral depression, a depressed fragment also over there. But you put it down there, but you make sure that the overall contour of the anterolateral distal tibia is correct. The anterior syndesmotic ligament will pull down the fibula. You will get a 90-95% correction of length. You then do a little bit of rotational correction and you'll probably be all there. You're never going to be 100%. Let me tell you that.
Professor Panchbabu, you want to add something?
Yeah, he raised his finger.
Yes.
Basically, what I want
he-
to say is, you see, I think Dr. Dhilan already mentioned that you need to reduce these fragments first before you actually give a final definitive fixation of any one of these. So, for example, if you did a final definitive fixation of lateral malleolus, you make it difficult for yourself to get the anterolateral fragment down or the medial malleolus down. So, what I would do is expose these fragments and temporarily fix them. We could certainly put a couple of K wires there or K wires in the anterolateral fragments to replace them with anterolateral screws. Then you can finalize your fixation on the fibula and then replace those K wires with screws. I mean, because somebody asked technical tips, I find that this works out easier, because if you provide a definitive fixation of one, it hinders your efforts to get fixation or reduction in the other ones.
Navin bhai, let's have another question.
One question
Yeah.
is, approach for this shepherd fragment and the fibula will be one approach, or will you take a two separate approach?
Mark, could you answer this?
Sure. I think it's always safest to use one approach, and you have all the information here from these CT scans. That is the information you need to make your approach. So I would do a fairly anterolateral approach to the distal tibia and the fibula all in one, and that will help you with your reduction.
Any other question, Navin bhai?
Yes, the question now the question is, approach has been taken care of, but the question is, before you start the question 3 or case 3, what was done later on, after how you reconstructed after that?
Okay. So yeah. So
After
when
this, yes.
this patient came to me after somebody else again tried to reconstruct. So it was like the second reconstruction somebody did. And then this patient came to me. By that time, it was too late. I had to go in for the fusion of this case. Okay. So case number 3. Female 34, road traffic accident, closed injury. Nimish bhai, what would be your diagnosis for this case?
Well, it seems like a trimalleolar, so a CT scan would be ordered for her to get to know what is going on here.
Okay. So which are the X-rays you routinely get for such trimalleolar ankle fracture cases? Would you diagnose it with the X-rays simply?
Well, in this, it seems there is a trimalleolar part, but generally when we see these patients in the emergency room, if we can put the ankle back together, at least we try to put the ankle into the joint and then put her in a slab and then take other x-rays. Generally, you don't need to take more x-rays because in this case, you are going to need a CT scan anyhow. So why unnecessarily expose the patient to more radiation in form of other x-rays?
Okay.
So
Dr. Vinod,
Dr. Vinod wants to add.
raising
Yeah,
the hand.
could you, Rajiv, could you put the X-rays back up, please? Just wanted to bring out a point, you see. So whenever I see this kind of X-ray, especially the lateral view, it gives me a very important information. It tells me that it's very unstable posteriorly. this is a definition of a posteriorly unstable fracture. So it has knocked off the posterior malleus. And if you look at the, if you can visualize the fracture pattern on the lateral X-ray in the fibula, it is much more oblique rather than spiral fracture. So it is highly unstable posteriorly. So that's a important information to get from these particular X-rays. You see, I don't think I can show my mouse on there,
but I'm showing, no problem.
yeah. So you see, it's going. The fibular fracture is difficult to assess on a lateral view, but you can make it out that it is oblique from posterior. On the posterior aspect, it is higher, and then as it goes down, it is becoming more anterior. It's more oblique rather than spiral fracture. So, and then you have a posteriorly subluxed foot, and that these kind of fracture patterns are highly unstable posteriorly.
Anybody suspecting impaction here to get
yeah,
the
a lot
CT
of
scan?
impaction. I mean, it's got almost more than 40% of the distal tibial pilon impacted. So we are talking about another kind of a different kettle of fish. But one point which Vinod talked about was the instability. So when you start to reduce this, you'll notice it comes very easily. So if it comes very easily, that means it is that much more unstable. And if you leave it like that, it's going to fall back that much more. So you're going to need much more than simple fixing of the fractures. You're going to need a lot of buttressing here.
So the question was, which are the routine X-rays for an ankle fracture case before going more forward? These are the X-rays in my ER. I would ask for an ankle case, a lateral AP mortise, but the joint above must always be included. And over and above that, for a posterior malleolus suspected case, I would ask a lateral view in 40 to 50 degree of external rotation. Even these kind of X-rays are really able to demonstrate you the posterior malleolus. That was the only point I wanted to bring. Now, this is a kind of injury in your OR. What next, Mark, for you? This kind of injury, what next?
Right, so I totally agree with Nimesh, and I would have a CT. In my OR, I would have this patient positioned prone, because as Mandeep has very brilliantly said, everything has come off posteriorly. And actually what we need to do here is apply buttress plate principles to the posterior aspect of the tibia and to the fibula, and that will restore the ankle. Now, clearly, if you're struggling to get reduction or you have a delay in the patient getting to theatre, then there's nothing wrong with applying either a decent plaster or an external fixator while you wait. My only tip would be is that I have seen these sublux even in a good plaster and even in a good external fixator. So you still have to be vigilant that even though you've achieved reduction on one film, it may not stay that way.
Can I add just one thing here? In these cases, which tend to subluxate posteriorly, what we have sometimes found is that we try to put a trans tibia into a talar K wire with an X fix on and keep the K wire buried under the skin. It prevents them from going out at the back till you are ready for a surgery. It's just a tip in some of the cases.
That's a bit of extra damage to the ankle.
Yeah, that will, but the ankle is not moving. You have already put in an X fix. So it's just 1-2 mm pin. You can take it out during the fixation.
Okay. So here is a posterolaterally placed posterior malleolus fracture. Professor Dillon, how would you move ahead with this case for a definitive fixation?
Yeah, once the soft tissue swelling comes down, this is one of the ideal cases to do a posterolateral approach, because with that, you will be able to do a reduction of both the lateral malleolus, the fibula, as well as the posterior malleolus, and you will be able to do buttress plating after reducing this.
Sir, could you for our audience slightly elaborate onto posterolateral approach and what position you do this approach?
Well, you can do it in two positions. One is the most comfortable for the surgeon, even if he has to work on the lateral side, is a prone position. You can keep them a little bit of floppy, but you can also do it in something like a floppy lateral position, which becomes a little more uncomfortable for the lateral side, but much more comfortable for the medial side. So what we do over here, and I've got my colleagues who are probably listening into this, what we do is we would do it in a prone position. We expose the posterolateral fragment, and then we go through two windows by retracting the tendons to the medial and lateral side. We first reduce and hold the posterior malleolus, check its reduction, and then temporarily hold the lateral malleolus out to length and rotation. Then you fix and buttress the posterior malleolus. Then you fix and buttress the lateral fracture, that is the fibular fracture. And then in our institute, what we are doing, and I think one of my colleagues, Sandeep Patel, and is also wanting to publish it, is you flex the knee to 90 degrees and you have the ankle exposed both medial and lateral sides on both sides, but it's in a reverse position. Just have to get used to it, and then you can open up the medial side and operate on it, in very easily. If
Dr.
you're doing it in
Panchbhavi.
the lateral approach, it's a floppy lateral approach.
Yeah, Dr. Panchbhavi, your
Yes.
way.
Yeah, can I quickly share my screen so I can show you what Dr. Dhillon has
Yes.
very nicely.
Yes, you share your screen. Automatically, your screen will come.
Okay, wonderful. So
I
let
have
me.
given multiple screen sharing allowed.
Thank you so
Yeah.
much. Thank you so much. Let me
Once you
just
will
go
stop,
down.
once you'll stop, it will go to the original one, Rajiv Vice.
Got it.
Got it.
With
Yes.
Dr. Rajiv Shah's permission. So, basically, I'm going to show this case. Again, I was trying to demonstrate that you see, this is what I was talking about. The obliquity of the fracture. Can you see all that? Can you see the highlight? Okay, so that is the obliquity. You see, so I was talking about very short fragment here, and you can see how unstable that is. You see, I mean, Dr. Mandeep Dhillon has mentioned, the more easily it goes back in, the more easily it has a tendency to go back in. Unless you provide a strong buttress, it will not, stay there. So you can see the little die punch fracture on a CT scan. And Dr. Rajiv Shah has asked us about the positioning. You can certainly do it in a lateral position. This is the lateral position here. You can do it in a prone position. Makes the medial approach slightly more difficult. But here is the lateral position. You can see that is the nerve there, right there. And Dr. Dhillon has mentioned you could make two windows. This is the window for the back of the tibia, and you can see the fracture there, right there. And you can put a temporary. Now, one point I would like to make out is, you see, I don't use a contour plate to go and hug the bone there. I under contour on purpose. It is staying out like that. So when you sink it back, then it will provide a much better buttress. So now this is the second exposure Professor Dhillon has mentioned about for the fibula. You can see again a very short oblique fracture there. You can hold those reduced, and you can get your final fixation. So, and this particular patient also had a anterolateral fragment, which we went ahead and then put in a small fixation there. So that's a 4-month post-op film. So that's all I wanted to show you for this particular case.
Great case. Now,
can we keep you on that your presentation, Vinod, because it's excellent. Could you just go back to the temporary K-wire fluoroscopy image that you showed?
Sure.
So,
temporary. Okay, so
next one down. Next one down, the fluoroscopy. So the key thing here is, yes, you've got illustrated it beautifully. On the left-hand screen, you can see the angle of the K-wire that is reducing the posterior malleolus fragment. Often the mistake that our residents make is that they go very much what appears to be at 90 degrees to the shin, and that wire is often passed into the ankle joint. Whereas you have to be very careful, and when you have your reduction, is to aim the wire more towards the head of the patient than you think. and that will get you the appearances that you can see on the left-hand side there of a perfect reduction with a good temporary fixation with that K-wire. I think it's well worth pointing that out.
Thank you.
Okay. So if we go back to that question to Nimish Bhai, yeah, can I share my screen?
Yeah,
Yeah.
yeah. You share your screen. Go to share. It will automatically come.
Okay. So coming back to the question,
You're not shared. You're not shared yet.
yeah, yeah.
Yeah.
So coming back to that question, that which are all posterior malleolar fractures, which okay, this is not moving.
Then share the screen, not the PowerPoint. Share the screen. In a share option, go for the screen only, not for the PowerPoint.
Hmm.
Yeah. Now it's okay.
Okay, so which all posterior malleolar fractures would you fix? So are there any posterior malleolar fractures which you would not fix? Mark?
Well, that's a great
Say,
question.
or I'm coming straight to this, that if this is the kind of posterior malleolus fracture, would you fix it or not? Why fix? Why not fix? Reasons.
Okay, so historically, what we were taught is that if you have a large posterior malleolar fracture, that is the indication for fixing. And people quote the 1/3, 2/3 in the AP plane. But I don't think that that's necessarily true. It's all about restoring stability to the mortise. So, in the X-ray that you have shown there, where there is a very small posterior malleolar fracture fragment, if you were to fix that, that will have some key ligaments that are attached to it, and that will restore stability to the syndesmosis. So it depends very much on how you view things, because, for instance, the X-ray that is shown there is likely to be accompanied by a very proximal fibular fracture, and that is a difficult thing to plate if you have a meson nerve type fracture. So this would be one where either you address the syndesmosis indirectly by screws and anatomically reducing the fibula, or you tackle the posterior malleolus, but I don't think you need to do both. So fragment size does have a bearing, but it all has to be taken into consideration with the medial structures and what's happening to the fibula, particularly with its length and rotation.
Yeah. Professor Dillon, you want to add something?
I agree fully with this. You have to look at the ankle joint like the pelvis. It's a ring. You have to evaluate on day one which segments are unstable. And you have to reconstruct the ring, and you have to make it stable from all sides. That's why the debate most times comes about from the medial side, deltoid ligament reconstruction was coming up. So over here, we must understand that if the posterior malleolus is avulsed, the posterior syndesmotic ligaments are attached to it. We have to bring them back. So if you don't bring them back, you will leave a certain instability, especially if you leave them displaced. Remember, the interior ligaments are gone. The posterior ligaments are intact, but the avulsion of the bone means that the posterior side is unstable. So if in doubt, I would much rather, I do a stress view over here. I'll see how unstable is the medial side. And if I am plating a fibula, then I'd much rather fix this also. And that leaves me with some choice of doing aggressively something, some fixation of the syndesmosis or not. But it's not what to fix and why to fix. The key point is the why. The key point is that you have to have the talus stable inside the ankle mortise. It shouldn't shift anywhere. And remember, it is to the talus and the distal fibula, the whole foot is attached. So the weight of the foot is going to move the talus around. So you've got to have it reconstructed and stable on day one to be able to allow ankle range of motion.
So this is the question to Professor Nimes.
Mhm.
Approach for fixing this fracture and position for fixation of this kind of posterior malleolus fracture.
Which one? The one with a
One,
small flake?
one which you are seeing here, how would you approach this?
All right. So yeah, if this would go into a Mason type 2, generally, well, you can take an extended posteromedial, or if you are able to get into that fragment, if it's more onto the medial side, you can take a posterolateral and a medial approach.
Could you describe posteromedial approach? How do you
Well,
take it?
in the posteromedial approach, it's on the medial side of the tendoachilles, but you can have all different windows through all the different structures there. So if you remember our mnemonics that talented doctors are never hungry, and you know the structures are there. So between those different elements, the you can go in and approach the different aspects of the posterior tibia. Generally, in these Mason type 2B fractures, where there are two pieces, it is recommended that you fix the medial fragment first and then you go on to the posterolateral piece, so that it's sort of, this is not the exact fracture line which he has described. The fracture lines are probably in one of the slides previously described by Dr. Panchbawi, that the posteromedial fragment is overlapped by the posterolateral fragment somehow. So you need to study the CT scan very carefully. And if that is the case, then you need to fix your posteromedial first and then fix your posterolateral fragment. That will how you would go about these fractures.
Patient would be positioned into which
Prone
position?
position, prone position, prone position.
So we have another 15 minutes and then I want to go into syndesmotic fixation. Before that, I would like Professor Dillon to sum up about.
Rajuvi, there are a lot of questions.
Okay,
If
so we
if
take
we can
questions.
extend,
Okay.
no, not just now, not after syndesmotic, everything over, but we may have to extend for 10 to 15 minutes if the
Okay.
foreign faculties are ready.
Yeah, Professor
Dr.
Dillon,
Vinod
if
and
you
Dr.
could
Mark.
summarize. Yeah, Professor Dillon, if you could summarize for our delegates the management of posterior malleolus fracture. Professor Dillon, could I request you to summarize management of posterior malleolus for our delegates, for our attendees?
His screen is freeze. Probably he has lost the connection.
Yeah, could we
So
ask Professor Panchbawi to do that?
Dr. Vinod?
I unmuted myself, so
Yes, yeah.
thank you, Rajiv. So posterior malleolus is really interesting, and Dr. Davis has already mentioned, so, and you also brought it up. Size was an issue. Size was the main consideration in the past, but size is no longer the consideration. It is the instability. The instability can be directly posterior, or it could be rotational instability. So you could have a rotational injury causing a posterior malleolus, or a direct posterior force which can knock out the posterior malleolus and then provide a posterior instability. So in scenarios where there is a significant amount of instability, no matter what the size is, the size could be less than 15% or even 30%, or whatever size is, but it is the instability, the direction of the instability we have to restore. So in those scenarios, we have to provide enough stability. So the best way to provide stability is direct posteriorly. So if there's a posterior instability, you need to buttress it posteriorly. So in those scenarios wherein there is a posteriorly unstable fragment, no matter the size, we want to provide a buttress in the back of the ankle, in the back of the tibia. So the approach could be either a prone position, like Dr. Shah has mentioned, or Nimesh has mentioned, or it could be posterolateral approach. So with the posterolateral approach, as Professor Mandip has mentioned, if you flex the knee at 90 degrees, you can see the medial aspect as well, and you can deal with the posterior malleolus fracture very well, as well as the fibular fragment. So getting the posterior malleolus down is a critical issue. So again, like we talked about the previous scenarios, we had to mobilize these fragments, temporarily fix these fragments, and you start off with posterior malleolus, definitely fix that fracture first, then move on to the other fragments.
So let's finish the last part of ankle fractures. And look at this. This is a case given to me by Dr. Rajiv Vora, present president of Indian Foot and Ankle Society. 17 years old female comes with an ankle injury, 10 weeks post injury with difficulty of weight bearing. Failed conservative treatment, rice kind of a principle, and so far treated as an ankle sprain. Pain in ankle which has increased in the last 1 week. Diffuse swelling at the ankle joint line with global tenderness. So a 17 years old female comes with this kind of picture. Mark, how would you proceed for this case?
So, assuming that's the only X-ray that we have, what I can see from the history and the X-ray findings are that we've got a young lady. It's a delayed presentation, and she's getting constant pain and swelling. That's telling you that there is a persistent problem that is not right. If you have a look at the X-ray that we've got there, I have no idea whether it's weight bearing or whatever. But what I can see that the joint is not congruent. It does look to me as if there is some opening of the medial joint space, and it could very well be that the talus is subluxated either laterally or is rotated abnormally, probably an external rotating view that we're looking at there. So that's the situation we're dealing with. For me, I would obviously do more examination, and there may be further stress views that we could do, or CT views or MR views, depending on what resources we have available to try and work out whether the deltoid is injured and whether the syndesmosis is injured.
So, Professor Dillon, would you like to get some other view, some other X-ray, anything else you would like to get for this case?
Rajiv, you'll have to excuse me. I think I lost my internet connection for the last
Yeah.
5-6 minutes, so I have not part of this. So I'll get part of the next case. Please
Right,
excuse me
sure.
for this
Are you
case.
sure?
Yeah.
Do you have the full length X-rays at all of the
Yeah. So Nimish bhai, there comes this X-ray.
Yeah,
Yeah.
full length X-rays. You see, that's where you see the fragment.
Yeah.
You know, it's a nose fracture, really. Sorry.
Yeah. So it's now 10 weeks. This injury in a 17 years old lady or old female. This is how it looks like. Professor Panchbavi, how would you proceed for this case? And what is your
Clearly, it
diagnosis?
is like I said, it's a meniscus fracture. So we have to get that fibula back in that tibia, fibula insusura of the tibia, fibular insusura, and it should be congruently placed. So many times you see when you fix the fibula into that the incisura, it could be either anterior or posterior. The more unstable it is, the more ways you can go get it wrong. So trying to get that syndesmosis healed is the main principle here. And you know, again, I look at the deltoid ligament, you know, in this. Sorry, somebody's saying. So in a chronic scenario, so I would like to get the fibular length and rotation and congruity within that syndesmosis groove.
Okay.
And fix it with a couple of screws.
So here comes a question for panelists, every panelist. What are your clinical parameters for diagnosis of syndesmotic injury? Mark, would you like to answer this? Your clinical parameters, how you clinically diagnose syndesmotic injury?
Well, I saw a test that I particularly liked by Ned Amendola in the States. And a good test for me for syndesmotic injury is if you were to bind the syndesmosis together externally with some gauze around the ankle and some tight tape. And you can ask the patient beforehand to see if they can go on tiptoe onto a single tiptoe raise. And quite often they find it too painful to do, may not even be able to do it at all. And if you were to bind the syndesmosis, in other words, you are trying to establish some stability of the syndesmosis, they can quite often do that after you have tightly bound their syndesmosis back together. And for me, that has been the best test in terms of giving me some idea as to whether or not the syndesmosis is injured. There have been tests such as the squeeze test and other tests that have been written up, but to be quite frank with you, I don't find them very reliable.
Great.
May I make a point here?
Please, please, sir.
One of the issues is that this particular case is got soft tissue injuries all around the ankle, number one. Number two, if the fibular fracture is very high, that means the interosseous space right up to the fibular fracture is also disrupted, making it doubly unstable. And thirdly, we are looking at a case which is maybe, if I'm not wrong, this is a few weeks
10 weeks.
down the line.
10
If
weeks.
it's a few weeks, if there is a lot of fibrosis both the medial side as well as around the syndesmosis. So trying to get it reduced by closed methods and other things is not going to work. So even if you do a squeeze test, this is useful. So there is a difference in evaluating clinically an acute syndesmotic and a chronic syndesmotic injury.
Right.
So that should be taken into consideration. Many of us try to apply the acute tests in a chronic, where often we go wrong. Secondly, the syndesmosis is not only rotally unstable, it is often vertically unstable. It is also unstable anterior-posteriorly. So it's a three-dimensional instability which we have to look at.
Okay. So now my question to every panelist, how do you intraoperatively reduce syndesmosis? Starting from Nimish.
Well, you need to you need to go and through an anterolateral approach, and you need to see the anterolateral corner where you'll be able to see the relationships between the tibia, fibula, as well as the talus, and you can do it under vision there when you are just dealing with a simple syndesmotic injury and syndesmotic fixation.
Okay, so you look for the reduction at incisura or at the joint?
At the joint, as well as, well, when you take an anterolateral incision, you can almost see everything around there when you open up the capsule there.
Professor Panchbhavi, would you like to see reduction at incisura or would you like to see reduction at the joint line, and why?
I want to see, basically you have to have extent. The more delayed the presentation, the more extensive the exposure would be necessary.
We're talking about acute case. We're talking about an acute case.
Acute case, yes. I mean, incisura all the way up to the joint line, to make sure that you see both is important. Like Nimesh said, I totally agree. Because you could go wrong. Again, you see, there are different types of incisuras. There are some patients who have a very flatter contour rate, some with much more deeper cup. So in a deeper cup, it's you're likely to not make more mistakes, but in a flatter incisura, you're likely to make more mistakes. So in a flatter incisura, you really need to get as many clues as possible to make sure that the reduction is good.
So Dr. Panchbhavi, so like Dr. Nimish, you want to go for open reduction and see the incisura. Right.
Definitely.
Mark, what is your way of reducing this syndesmosis?
I think it has to be via an open reduction. Too many mistakes are made simply by putting a very large pelvic type clamp across the fibula to tibia in the acute setting and simply squeezing everything together. And what you can find is that patients can often have the fibula anteriorized and squeezed against the anterior lip of the incisura. So I think it has to be an open technique in order for you to get anatomic reduction.
Dr. Dillon, would you use a clamp and would you do an open reduction?
Open reduction always. Now remember, we are talking about a chronic case. Are you talking about general statement or are you talking about this particular
I'm talking about the general case.
General. All acute cases, you should do an open reduction, visualizing the interior lip of the syndesmosis. I particularly like the point which Professor Vinod brought in, because there is a little understanding about the fact that the syndesmosis anatomy anatomy itself may be different in different populations. There's a very good study out of Japan recently, which has talked about there's the Asian syndesmosis in scissuras being a little flat, but we don't know whether it applies to the Indian population. Be as that it may, you have to bring it back to its original position. And as I said, you don't only have to look at it from of the height of the fibula. You have to look at the rotation, the AP translation. And I would never advocate a compression. So one study which was published a few years ago by Gardner also talks about placing the clamp. If you're placing the clamp, it should only hold it. And it should also be held in a 30-degree oblique position, like because the fibula is slightly posterior, and just hold it. I prefer most of the time to just hold the syndesmosis by a wire or two rather than by holding it with a clamp, which I could tend to compress. And if I compress, the fibula would shift probably to the back because of the obliquity, but it can also go to the front. So you have to reduce it, you have to hold it, you have to see not only the syndesmosis positioning, you have to see the talus positioning also, because the whole thing depends upon whether the talus is in the right place, and then you go and fix it.
Dr. Nimish,
Yes.
how do you acutely reduce the syndesmosis? By open method, and do you use a clamp?
Well, if it's an acute injury, generally a thumb pressure will reduce the fibula into the notch of the distal tibia. You can hold it with your hand, keep it reduced and put 2 K wires like Mandeep has said. And then once you are satisfied with the reduction, you can go along with the syndesmotic fixation. The clamp at the most, you can just put it as a positioning tool, not as a compressing tool.
Well said. I
And
always
position of the clamp. Can you say the position of the clamp,
Yeah.
Rajiv bhai?
Professor
There are many
Vinod has
papers.
already mentioned that the position of clamp has to be perfect. It has to be on a medial surface, and it has to be put in such a manner that it is mimicking the direction of the syndesmotic screw. I, over and above this, like to put an anterior blocking wire just anterior to the fibula. So whenever I'm pushing my screw or my tightrope, fibula does not slide anteriorly, because Gardner came up with the studies that the antero-posterior instability is more dangerous, more worrisome than the mediolateral instability. Anything, Professor Panchbavi would want to add on to this?
Yes, you see, Professor Dhillon has made a good point, you see, because when you apply the clamp, what can happen is the torque of the clamp can shift. And Dr. Rajiv Shah's tip is very good because, with that torque, the K-wire, even the torque can come when you're inserting the screw. So that K-wire can actually block. If you're not careful, and you can tighten and over tighten these screws, what happens when you over tighten these screws, you see, because again, the fibula is a plastic structure. We actually did a finite element analysis to prove this. And also clinically, I've seen scenarios wherein you put this syndesmosis screws a bit higher. So, if you squeeze your forearm, you see the forearm bones can be squeezed. Similarly, the tibia and fibular bones can be squeezed too much. And if you put syndesmosis screws way higher than the tibial plafond, say 4 centimeter higher, 2 centimeter higher, 3 centimeters higher, I've seen 5 centimeters higher. So we can squeeze that interosseous space so much that the distal end of the fibula moves away from the talus, you see. So we have to pay attention to these things too. So, again, there's a lot of controversy about 3 cortices, 4 cortices, where you put them, how do you put them. But the bottom line is, don't mess with the fibula. You want to just reduce it, not overdo it, not underdo it. Put it in the right place.
Thank you. So we have to, cover the questions also. So 3 quick questions to every panelist. Starting from Mark, how do you intraoperatively assess reduction of the syndesmotic injury? How do you fix syndesmotic injury? And what would be your postoperative protocol? 3 questions to each of the panelists turn by turn. Starting with Mark, please.
Okay. So one tip, we've seen an X-ray already this morning of the spiral fracture of the proximal fibula. I think when they are fresh injuries, it's a very useful thing to use the image intensifier to screen the fibular rotation at the level of the fracture. You know that the peroneal nerve is going to be there. You're not going to go in and put a plate and reduce that fracture, but you do need to be mindful of it being reduced because that helps you restore length and rotation. The second thing is actually having a look at the relationship between the fibula and the talus and the distal tibia. And there's plenty been written showing you which are the key signs that you need to assess. But as we've already said to you, the open reduction is the gold standard here. So provided you can literally manually reduce the syndesmosis, temporarily hold it with a wire, then you should be fine. How do I fix it? I think it depends very much on resources. So again, we have access to screws, and I would ordinarily use 2 screws if there was no other fractured distal within the fibula. And I occasionally use tightrope anchors as well, but I do have some concerns about how good they are in terms of fixation. In terms of my post-operative regime, I think because we're dealing with a ligamentous injury, I am much keener not to get patients walking on it as unlike with my standard ankle fractures, where as soon as we have wound healing at 2 weeks, I want to have the patient with range of motion exercises. You've created a stable ankle fracture, they should be able to walk on it. I think syndesmotic injuries are different. You have to be more respectful of them.
Okay. Professor Dillon, how do you fix it and your post-operative protocol?
His connection is gone. His connection is gone.
Yeah, Nimish bhai, could you answer this? How do you fix it and your post-op protocol?
So if you are just fixing a syndesmotic injury, not in with bimalleolar or something like that, probably my protocol for fixing the syndesmosis is just use a 3.5 millimeter just suprasyndesmotic screw, just above the as near to the plafond as possible, but not through the distal tibia fibular joint. A screw not that is not 4 cortices but 3 cortices, but long enough so that you get a good purchase on the opposite side. If the bone is osteoporotic, as in an elderly, probably I would like to put 2 screws. Generally, our trend is that around 3 months we tend to remove these screws under local anesthesia. Once they have started weight bearing, we allow them weight bearing, and after we feel that the fractures and most of the things have healed properly, around 3 months or 3.5 months under local anesthesia, we tend to remove them.
Okay. Professor Panjbavi, your viewpoint?
Yeah, for the fixation, agree with what Nimesh has mentioned. I'm one of those folks who is near the plafond rather than away from the plafond. And I have this argument all the time with trauma colleagues, who prefer to go way away from the plafond. But I think fixing it closer to the plafond, in fact, putting one through the epiphyseal scar provides you a great fixation. And I use fully threaded cancellous screws. Again, I pay attention not to overdo it or underdo it. And the size, sometimes Texas, you get very huge folks. Everything is big in Texas. So sometimes I have to use 4.0, 4.5 millimeter fully threaded cancellous screws. Diabetic patients, totally different kind of game there. You might need to, if they have any sense of neuropathy, you need to put multiple screws. And then the post-operative protocol, whether to remove them or not, has been a controversial issue. The patient do complain about some tightness in their ankle at 3-4 months, then I tend to remove them. But if the patient is happy, then I'll leave them well alone. They know that they may break these screws, non-weight bearing up to 6 weeks, and then start them bearing weight and get back to their lives, basically. So that's the way I'm dealing with these syndesmotic injuries currently.
So why are you not using tightrope?
Tightrope, you see, tightrope is good in certain scenarios. There has advantages and disadvantages. You see, the tightrope doesn't provide vertical stability as much. It's expensive. Multiple studies have shown equivalent results between tightrope and screws. Screws have done very well. They provide stability in all directions. So I think just because it's new and probably more appealing to some people, I'm not totally convinced that's necessary all the time.
So now we got Professor Dillon back. So sir, quickly, how do you fix syndesmotic injury and your post-op protocol? And one more thing, you have an intraoperative O-arm. So tell us
Yes.
something about your way of doing this.
Well, it's the same overall, but you have the advantage of making sure. I mean, the O-arm doesn't really help you for the longitudinal instability, but the O-arm helps you in the AP instability and the degrees of rotational instability. Because if you have a C-arm, a CT scan intraoperatively, you can realize that you may close or open or leave close the syndesmosis from the front and the back. So it helps. It's on my. I've been taught how to use it by my younger colleagues who are more tech savvy. So we use it for most of our ankle and other fractures, etc. So it helps, but fixation depends. Now there's a lot of I didn't hear some of this previous discussion because I was sort of left out by my bad connection. But there are some evidences in favor of
So again, we are finding
rigid.
problems with the audio.
Oh,
If you
then
stop
maybe
the
somebody.
video, if you can stop the, I can stop the video, then it will come.
Okay,
Okay, the
let
voice
me
will
see.
come. Yes, I just
Is
stopped the
it
video.
better?
Yeah, it is better
Is
now.
it that?
Video
Okay,
signals will take
now
away your bandwidth. That's why
no problem, no problem. I will just answer these
you will
questions.
not be seen.
Now,
Everybody knows you. Everybody knows you.
doesn't matter. So the issue is the key point in the syndesmosis is reduction. Second point is maintaining the stability. Now, the other issue which we are realizing now more often is that maybe we are being too rigid with fixing the syndesmosis. That's not really normal because whenever you walk, whenever you are allowing weight bearing, you've got to have a little bit of fibular rotation along with it. And this is where tightrope helps. So with the tightrope, even if you've got a bit of rotation off, it allows it to settle in its place. So no great evidence in favor. Conventionally, we've been using screws and we've been using one screw. Sometimes if they're very, very unstable, two screws. And as Vinod told us, they shouldn't be too high because then you will tend to angulate this. However, they shouldn't be too low because remember the syndesmosis is a fibrotic joint. You really don't want to destroy that joint. So just above the syndesmosis is the ideal situation. What about post-operative protocols? It depends. If it's a complex trimalleolar fracture in which you've done buttressing and you've also fixed and stabilized the syndesmosis, depending upon the soft tissue healing, you could allow them some ankle range of motion in a few days. The key point is to prevent the ankle from going into Aquinas, which it tends to do. So some kind of splintage to hold the ankle in neutral flexion and then mobilization. Weight bearing actually depends upon the degree of instability, the degree of sort of comminution which you've encountered, and we tend to defer it for a few days.
So Dr. Navin bhai, we would like to.
Can we take to the questions, sir?
Yeah, I do
If you
not know
allow.
about the availability of Professor Panjwabi and Dr. Davis.
Are you okay, sir? Both
Yes,
10 to
thank you.
15
This has
minutes,
been a
15, 20
great
minutes? Okay.
discussion. I haven't got
Yeah,
any calls.
10 minutes.
So, okay.
5 minutes. Okay, fine, fine.
If time allows.
There are a couple of questions about the tight rope. Dr. Jawar Jetwa is asking that, especially in this case, injury, tight rope is better than the screw as rotational alignment is taken care of automatically along with other parameters. Is it true?
Dr. Panjwabi to answer this question.
Yeah, I mean, sure, there are some advantages, like Dr. Professor Dhillon has mentioned. It can suck it into groove much better. The screw can displace it, but it does not provide vertical stability, though. So if it's a vertically unstable scenario, you can have that vertical instability despite, and then tightrope can become loose because the tightrope works in a different ways. So basically, there are buttons, endo buttons. Okay, so one endo button is on the medial surface of the tibia, right? So when there's a constant pressure on the bone, what does bone do? It absorbs. So the tissue absorbs under the button. So the tightrope is designed not to be tight for a long time. So it can become loose. Hopefully, it doesn't become loose before the ligament heals. So that's a disadvantage. Those are two main disadvantages with the tightrope. But you can achieve a more flexible fixation with the screws as well. Like Nimesh has mentioned, instead of putting 4 cortices, you just do 3 cortices, and there will be play. There has to be play between, like Professor Dillon mentioned, it's not just vertical motion, but also external rotation motion when you move ankle up and down. So that's why you see those radiolucent halos around these screws, because it shows that there is motion there. And screws do provide that motion. It doesn't have to be tightrope. Tightrope provides motion as well, but maybe better than the screws. But you know, screws have done very well for so long, and then there are no studies to show that the tightropes are much better or significantly better than the screws. So I continue to use screws for most part.
Okay, next question.
Next question is from Dr. Karkhanis from the Mumbai senior orthopedic surgeon. In that case of 17 years old female patient with Bessenova fracture, the deltoid ligament needs to be reconstructed too, since it is probably external rotation injury.
Okay, point noted. Next question.
The next question is from Dr. Gopal Khela from Nagpur. For you, usually the posterior subluxation of the fibula is occurring in the syndesmotic injury. Why anterior placing KY, not the why not the posterior KY to not to get it displaced posteriorly?
See, it is not only the posterior one, it is the anterior subluxation of fibula, which is also equally important. When I start this case, I have an X-ray, lateral X-ray of the opposite ankle lying on my view box. So that is the one which is very, very important for me. And you have seen this being with me as a fellow, that I paint and drap both the lower limbs. And
Okay,
I
he was your
anterior,
fellow Gopal Khela from
yeah,
Nagpur.
Gopal Kela from Nagpur. He was my fellow. So, and I put an anterior blocking wire. So before that, I obviously put a wire to keep this syndesmosis reduced, and then an anterior blocking wire, which makes me a little relaxed about I not moving it anteriorly. Anyway, go to the next question.
Can I also add to this?
Yeah.
Why I think Rajiv's idea of the interior wire is important, because we are making a 30-degree and posterior to anterior tilt of this screw. So if we by error over tighten it, we are probably going to push the fibula anteriorly and not posteriorly. So that's the reason why Rajiv's anterior K wire seems logical, and you are there. Putting a posterior wire is very, very tenuous. You'll have to have a different approach altogether.
Right, sir.
Next question to Davis.
Dr.
Can I quickly
Kothadia.
add to that?
Dr. Kothadia, yeah, you can add it. Yes, sir.
Thank you. So the other point I have noted, you see, is that we put a bump under the heel. So what that does, you see, the foot and the fibula goes more anteriorly, you see, with the bump. So you have to be careful for these things. So that wire will prevent, not only when you are putting the screw, that torque which takes the fibula up higher, but also any forces where you put the bump is very important as well. So I think that's a really good technique tip. So you see, there you go, to the bump, you see. So if you put the bump under the heel, it has a tendency to push the foot and the fibula, which takes the fibula as well with the foot. So you could cheat anteriorly. The more unstable, the more severe the soft tissue injury, the more unstable the fibula is, and the more unstable the fibula is, the more ways you can, screw it up, really, or get it wrong.
Right.
Okay.
Dr. Kothadia is asking about what about the Mercedes-Benz sign? Nobody has shown the figure, so some junior people were asking, is there any picture that we can see that?
I'm going to show that picture. Actually, Dr. Panchbavi did touch upon this point. I'm going to quickly run through my way, my logic. I paint and wrap both the lower limb, lateral film of opposite side on the view box, open reduction of syndesmosis, finger dissection to reach enterolateral. I'm going to,
Yeah, no
I don't
problem.
use a clamp. I do reduction with the fingers, direct visual assessment of reduction at the joint line for looking at the Mercedes-Benz sign and anterior blocking K-wire. I think I had a picture of Mercedes-Benz sign, but I've missed somewhere. Anyway,
So,
but it is at the joint line. Dr. Davis as well as Dr. Panchbavi both mentioned that you see reduction at the joint line, and what you see at the joint line is your Mercedes-Benz kind of a sign. Let's go to the next question.
whether it is a comment or question, it again from the foot surgeon, Dr. Girish Motwani from Nagpur. If you require more force of clamping to reduce the syndesmosis, does it mean good chances of mal reduction? If you require more force on a clamp, then it
Then there's
goes
something wrong somewhere.
something wrong
If you're
somewhere.
not able to, if you are
Yeah.
not able to reduce it, you are actually pushing with your clamp. Then there is some obstruction of the talus shifting. Remember this, that when you, the distal malleolus has the talus attached to it. You're not
Yeah.
only reducing the syndesmosis, you are shifting the talus. So there could be some fragment on the medial side or something. If you need to apply too much force, look elsewhere to see why you need to apply too much force.
Yes.
So
So
any
now,
other question?
yes. There is a question in posterior malleolus. How do you address the die punch part, intraarticular, something in the intraarticular with the posterior malleolus?
May I ask Dr. Davis to answer this?
Yeah, it's a good question. Often you get a die punch fragment that is involved with a larger posterior fragment. And in a fresh fracture, it's relatively easy to pass a McDonald tool along the fracture line and to open it up. And you can either see the fracture fragment and remove it if it's small, or you're in a position whereby you can manipulate it back into a reduced position. And then you can reapply the posterior malleolus and reduce it. So that would be my tip for dealing with the die punch.
Okay. Now the question is regarding that same case. There was an anterolateral fragment. That was the Shepard fragment, and the problem there. Do you advise the plate fixation or a simple 2 screws for that Shepard fragment with the fibula?
Yeah.
This single incision, you said,
Mark,
Dr. Mark. Yeah.
Yep.
Mark, would
Yep.
you like to answer this?
Yeah, sure, no problem. I think in the case that Rajiv showed, he's going to put it up again. I'm not sure that an anti-glide or a buttress plate necessarily would be the right thing here. I think this is all about achieving an anatomic reduction. So for me, I would probably put 2 screws with a washer to control rotation of that fragment and to make sure that it's nice and stable. But on occasions, you do find, particularly when they look more like a pilon fracture, that you can use an anti-glide technique and a plate.
Okay.
Well,
Then
if I may
same
add.
person is asking. Okay, you edit, please.
Yeah,
Nevis, we edit.
you can use plates from the 2.4, 2.7 set of distal radius. They are
Yes.
small plates. So if you are
Yes.
afraid that the fragment may shatter while you are putting in your screws, you may need a buttress plate. So
Yeah.
you need to keep them ready.
Yeah.
Those are small plates and they act as a big washer.
Yeah, the plate without the screw in the distal part.
No,
That would
you
work,
can.
I think.
Yeah, you can put the screws through the plate also, but the plate distributes your force over a large area, so it will act as a large washer and not shatter the fragment.
I'm
Again,
afraid Dr. Davis might have to leave. And I would.
do you want to continue with the other faculties? 2
Yes,
or
we
3
can
questions are
continue,
remaining.
but I just want to. Say a
Thank
big
him.
thank you to Dr.
Yeah.
Davis.
Thank you.
Very much for being with us, and you really stimulated us with your knowledge and expertise. Thank you very much, Davis.
Thank you, Dr.
Thank you very much.
Dr. Davis from Gujarat Orthopedic Association. Thank you for contributing and sharing with the audience. Now I got the figure that around 5,600 people have joined. Click the link on the website.
But
Fantastic.
then
Thank you for
quickly,
inviting me, and stay very well, all of you.
yeah. And if
Stay
you could
safe,
just quickly
everybody.
say how you recovered from corona.
Yeah, your story, please, sir.
2 weeks ago, I started to feel unwell. I didn't have a cough. I did have a fever. I did lose my sense of smell and my sense of taste. And I had general myalgia. And I was lucky enough to be tested, and I tested positive about 10 days ago. And I recovered fully last Thursday when Dr. Shah very kindly rang me to ask me whether I'd take place here. Last Thursday morning, I was nailing a femur. So good luck to you all. I'm hoping if you do get it, it's very mild, but I want you to stay safe, and my prayers are with you all. Thank you very much.
Thank you very much.
Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you. Thank you. Thank you. Can we go to the next question?
Yes,
The
yes.
same person has asked, he had asked to Mark, but he has gone. How many incisions in that case? 2 incisions or 3 incisions?
Nimesh bhai.
Well,
That shepherd fragment, fibula comminuted, and the medial malleus. How many
Dr.
incisions?
Nimesh.
I think 2 incision, one for the medial malleolus and one
Yeah.
is an anterolateral incision. And you can, it's not that you need to plate the fibula from the lateral side, each side. You can plate the fibula from the front also if you need be.
Yeah.
So the
Yes.
anterolateral will take care of it.
Yes, yes, yes.
Okay.
Absolutely
Any other
correct.
question?
Absolutely correct. One question for Dr. Vinod
Yes.
is you said that the fibula you use the straight plate. So how to mold that straight plate, whether it is requiring molding or it doesn't require any molding?
Can you share your screen for that, Professor
Yes,
Vinod?
I can. I can. Do you mind if I show some?
We all have time, provided
Okay.
you have time.
All right. Yeah. Yes.
You share the screen, please.
Yeah, I'm trying to share. Okay, so let me see if I have some of those cases to show why under contour or contour. I think we saw that case there. Let me see over here.
Yes.
Well, while he's searching for a case, I'll just like to add, not only do you need to under contour the plate, but you need to start putting the screws from top to bottom. You can't put a screw one on top and one on the down. If you do that, once the plate starts to contour, you lose reduction at the bottom. So you need to start at an end and come down when you are using an under contoured plate.
Yeah, let me.
That's a good point, Nimesh.
I
Good
think,
point.
so let me see. I can show you an example, I suppose. If Dr. Rajiv Shah, you have.
Sir, please go ahead.
Thank you.
No issue, sir.
So basically, you see, where was I? I don't know why this is. Let me see where I was. Sorry about that. Okay, so.
No issue, no issue.
Okay,
Till
so
that time, there is one question. For impaction, do you need a bone grafting there?
Professor Dillon, for an impacted posterior malleolus fracture,
Do you need a
would
bone
you
graft?
do bone grafting? Again, we have lost his audio. Dr. Nimesh, would you do bone grafting for an impact?
Dr. Dhillon, can I stop your video so that you can answer?
Generally, the posterior malleolar fracture are not as bad as the lateral condyle tibia fractures. And generally, what is required is getting the posterior inferior tibiofibular ligament healed because it's with a big bone piece. If you really see those x-rays, the posterior malleolus generally is not more than 25% most of the times. In the large, when you have a pilon, it's a different story altogether. But in general, you don't require bone graft there. Once you reduce the articular surface, you can put a subchondral K-wire, and once you buttress it, everything stays in place. I've never found the need to bone graft a posterior malleolus.
Yeah, same here. Professor Panchbhai, now over to you for your case.
Okay, wonderful. So basically, you see, what I was going to show you, these cases look simple enough, right? I mean, you can see a lot of soft tissue swelling, but a straightforward fracture. But this is the point I was trying to make, you see. So if you see a big gap like this, you see, so, that means that the deltoid ligament is, gone, pretty badly gone there too. I mean, severe disruption. So this was done, I came across this radiographs, and most people would say, well, this has been reduced well, and you can see that the medial ankle, the medial gutter is nicely almost congruent there. So, but here there is some trouble here. You see, I don't see the congruity, but this was the second picture and the third picture, and they did a picture in the cast on the same day. You can see 7/11/2018. But this is what I saw. This particular patient was pregnant at that time, and they said, "Can I take this over?" But I never saw her again. But this is the last X-ray I have of this particular patient. You can see the amount of instability down there. You see, that's why, I say, we have to pay increasing attention to the medial side of the ankle as well. We always been trained to fix the bone, but we don't do as much or as good a job when it comes to soft tissue. This is one of the examples which I've shown before. You can see these are the intraoperative assessment to see if the medial gutter can be reduced. This is my hand over here trying to abduct the talus into the medial gutter, but it's not possible. So you see, the reason is this particular big fragment was obstructing the reduction. And this is the deltoid ligament completely torn. This is my probe inside the ankle joint. Now, if you can see, once the fragment is reduced, I'm able, this is a talus right over here. That's a talus, and you can see that is the medial gutter, and you can see before, if you see the fragment here, and that was why this was not being reduced. You can see the gutter space being reduced in the comparative intraoperative images. You can see. Now I'm trying to assess. Now, if you look at the contour of the fibula, I actually under contoured it. Even after under contouring, you can see a little bit of a curvature there. You see. So imagine if the plate was like this, and I put this thing, that little fragment will be drawn that way. You see. So that's why I try to keep make the fibular plate much straighter than what it comes out of the tray. So
I agree.
I found that was unstable. So I went ahead, and you can see how much, after fixing this, you see, the syndesmosis is intact, but you can see that amount of instability can be uncovered, and then you can certainly use a cast and then mold the cast with inverting the talus, pushing the cast in such a way that, this talus will stay reduced in the gutter. But the alternative is to do the fixation, which is increasingly what I'm trying to do. So you can see how the straight is the fibula is, and the fibular plate is. Sorry, you were saying something?
Yes, I was saying that I also a less threshold to go in and do the deltoid reconstruction nowadays. So I also gone on to opening up of the medial side and doing the fixation of the deltoid, as you have been doing.
Excellent.
Again,
So,
but there is a debate going on. So we do not want to enter into the debate. Navin bhai, any more questions?
Rajiv, special question to you. Can you have a figure or image of your putting the anterior wire in a syndesmotic injury? Do you have any clinical pictures?
Yeah, yeah. So
Till
we
that time,
wanted to discuss.
till that time, Dr. Sunil Kulkarni has asked Dr. Vinod, the Haraguchi type 3 posterior malleus, you don't recommend to fix it, or you recommend to fix it?
let me see. What was the question again? Sorry.
The question is the Haraguchi type 3, as per the
Well,
classification of Haraguchi type 3 posterior malleus. You don't recommend to fix it, or you recommend to fix it?
Again, my philosophy for posterior malleus is the instability. See, so as long as it's unstable in the posteriorly, so I put a posterior plate.
Okay.
no, can I take that?
So the coin, we have coined the word that the size of the fragment doesn't matter, but
Yes.
the instability does matter.
Absolutely.
Can I take that?
Yeah. Okay. You take it.
All right. So, well, if you are in doubt whether you need to fix the posterior malleolus, which is a small piece, or not, you can do a comparative CT scan of both the ankles. And if you find that the distal tibiofibular joint space is increased on the side on which there is an injury, you need to fix that small fragment too. That is one of the tests I try to find out if it's a very small fragment.
Okay. One question from Dr. Girish Motwani from Nagpur. Incidence of concomitant ATFL injury with syndesmosis.
Yes.
Dr. Vinod? Incidence of concomitant anterior tibiofibular ligament injury with syndesmotic injury.
Yeah, there was a patient, there was a case which I wanted to show, but due to paucity of the time, we could not really show the case. But in that case, I do not know we have the time to go for that case.
You can show if other faculties are ready.
Can I show you this particular thing? I was talking about the.
Go ahead.
Yes, sir. Yes, sir.
So you see, I mean, this particular case I came across, we can see clearly how we can overdo the syndesmosis. You see, so once you look at the introsseous space here, and then you know what's happening here. You see, once the screws are broken, the introsseous space has come back. You know, there are some studies which shows that after the screws break, the patients feel better, or if screws are removed, the patients feel better. That's all I just want to say about this.
The same question somebody had asked here. Same question. So that this question is satisfied. I was going to ask it. Okay, that's done. Somebody has asked about what about the chronic syndesmotic injuries? Can you elaborate on that? Chronic syndesmotic injuries and chronic pain due to syndesmotic injury, which are missed syndesmotic injuries.
Yeah. Professor Panchbhavi?
For the chronic syndesmosis, depends on how badly displaced the talus is, you see. So the more time has elapsed from the injury to the presentation, the more scarring there is. See, and the more disrupted the ankle there is, the more need for mobilization, extensive mobilization, sometimes to the extent that you may have to do a fibular osteotomy to bring the fibula down. Depends on where exactly in the fibula the fracture is. If it's a very high fracture, really, you can't do anything about it if you want to restore the anatomy distally. So you have to do extensive mobilization of soft tissue.
Can I show a case onto that?
Oh, please do.
Yeah.
Let me
yes, sir.
get out of this.
Yeah. So
no. You can keep your screen, no problem. You can multiple screen sharing is I have permitted. I allowed that.
So
enabled it.
Are you able to see this?
No, we are not able to. Just take care that you share the screen. Share the screen, sir.
That is what I'm trying.
Share the screen.
Okay.
Not the window, but the screen, so that you can share anything from your computer.
Okay.
Yeah.
Okay.
Case
so,
11 came.
Yeah. So this was the case. A male 48 non-diabetic had a closed injury. These are his injury x-rays. And then surgeon did open reduction and internal fixation of fibula. And then this was 4 weeks x-ray. There was some induration at the level of fibular fixation. And if you could closely look at this arrow.
There are spikes of the bone.
Yeah. And then infection sets in. Surgeon did debridement, removal of the plate, and he put in a bone cement impregnated K-wire. And thereafter, at 4 months, patient is walking with pain, limp and swelling. And his complaint is pinching of the pin and warmth, feeling of the warmth at the level of lateral scar. And that's the standing anterior picture of the patient. And this is a standing posterior view of the patient. And this is how he walks. So it is 4 months. Somebody asked about the chronic syndesmotic injury. So 4 months post-op and no infection. So what next, Professor Panchbavi?
Do we, let me see the x-rays again, please. I mean, just looking at these x-rays, it's difficult to know what the articular surface status is, but you know, these patients sometimes don't put all the weight in there, and then you'll be surprised the articular surface may be intact. But you know, getting a CT scan, if possible, would be great to see the, because you know, obviously, if you want to restore the anatomy, restore the ankle joint, we need to have good articular cartilage there. Now, if articular cartilage is extensively damaged, then the answer is simple: ankle arthrodesis.
With the
But
good articular cartilage,
if the articular cartilage is destroyed or gone,
it's good. It's good. Then at 4 months,
it is good. Then yes, we can certainly restore the length and you know, repair the syndesmosis to probably give the person a few more years of his native ankle.
Nimish bhai,
Well, this is more of a complex injury. If you see, he has a posterior malleolar fracture. If you go to the previous injury films or immediate post-op, there is a large triangle. No, down there. You can see there is a large triangular posterior piece. So his articular surface is not congruent at all. And the posterior half, it's almost like a half of the distal tibial fracture. So you will need a CT scan here, and there will be a significant step in the distal tibia in this case.
Yes, it has gone up. That fragment has gone up.
It has gone up. So
suppose you are reconstructing this, would you accept this step? This is less than 2 millimeter.
I don't think it's less than, unless there is a CT scan, I won't believe you.
Okay.
But
There's a significant step. If you see in the lateral, in this case, you can see that the articular surface has migrated, and it's a huge piece at the back.
You have
So suppose you have to reconstruct this, how would you move ahead?
I would like to send the case to you. I won't touch him.
Okay. So let me show you what I did. There was no infection. So I opened it on a medial side. I cleared the medial gutter, and you can see this. And then I went on the lateral side. He had no infection, but he had this cement impregnated wire which was impinging. So I removed it. For this particular case at 4 months, I thought of accepting that stab of posterior malleolus, which to me was acceptable. And so this was the case. In a chronic case, I do use a clamp, and I did this kind of syndesmotic fixation. Medial side was open, and then I could close it. And this is at 8 weeks post-surgery. There is no pain. Patient is walking, and he has full range of motion. This was operated at 4 months post-surgery, index surgery.
Okay, sir. What you did clearing up the syndesmotic space, and it was arthrodesis of the syndesmotic joint or something like that?
No, I did not do arthrodesis of syndesmosis. And you see, he has got good dorsiflexion and good plantar flexion.
That's why asking.
So I did a syndesmosis. Yeah,
you had to clear up that syndesmotic space, because there must be so much fibrosis and tissue.
Yeah. Professor Panchbavi, you want to add something?
Can I show a similar case which...
Yes. Go ahead, please, sir.
Thank you. Thank you so much. So let me see. You see, somebody asked about this
contouring of the
plate. I was able to find that slide. So basically, you see, that's how it comes in. So I remove this bend over here and make it straighter, see, like that. So that answers that question. And now Nimesh has actually mentioned, you know, how you would, let me go to that other presentation. How you know, it's important to also realize sometimes the posterior malleolus. You see, so if you want, this is similar, not as extensive as Dr. Rajiv, or not as difficult or as challenging as Dr. Rajiv Shah's case, but you can see again we are dealing with you know, possibly a syndesmosis injury, but again a severely malunited fracture. Again, you know, you can see it's subluxed as well, in the posteriorly subluxed. You can see that the posterior malleus is there, but the point I wanted to make here is, you know, sometimes you have to go, this is the medial exposure. I'm trying to mobilize that fragment, you see. So until you really mobilize that fragment, you will not be able to bring it down at times. So, extensive mobilization is required, and you can certainly get some mileage. I don't know how long it will last, but I haven't seen her again since past few years. So it is possible to restore this ankle joint, even if you're not able to salvage the ankle joint. You made sure that the ankle is in a good position for a future fusion. I just wanted to show you a similar case where I came across this.
So, do we have more questions?
Let me check. Let me check.
Yeah.
New questions
Well,
have come.
I just
a minute.
wanted to show one
Again,
case.
again, Dr. Karkhanis has asked same question. Whether his question is not answered in that Massenova case, his question is whether to reconstruct the deltoid ligament or not.
Professor Panchbavi.
In this particular patient, or
No,
which
no,
particular?
not in the Massenova fracture. Young
This
patient,
case.
the picture Massenova.
I'm sharing my
Yeah, he's sharing the X-rays for Dr. Karkhanis. The case where there was a Massenova and there was no fracture, deltoid repair is required or not? That
this
was
case.
No, it's not required.
syndesmotic. Not this case. Not this case.
No, if
This
I
is the
may,
case. This is
if
the
I
case.
may, if I may reply diplomatically to Dr. Karkhanis, well, once you have done the syndesmotic fixation in that case, if you do a gravity lateral X-ray in the OR, and if you still find that the medial joint space is opening up, then you need to go in and fix up your deltoid. Probably that's how I would do it in that case.
Okay. So I just wanted to share one case and then we close.
Yeah. There is one question of any role of arthroscopy, Dr. Vinod.
Absolutely.
Yes, I mean, we actually have published a series of patients in JBJS long time ago. We found that, the more severe the ankle fracture, the more number of intra-articular lesions you can see. And one case I just showed, there was a massive fragment. I was not able to reduce the medial gutter space. So you could certainly, open up the medial space and probably could have gotten to that fragment. But ankle arthroscopies, you can just use two small portals. Obviously, you have to be careful about the anterolateral portal. You can, if you're not familiar with ankle arthroscopy, you may damage the superficial peroneal nerve branches there. But it gives a good assessment. Sometimes you can assess the syndesmosis. Sometimes you can deal with this loose osteochondral fragments. You'll be surprised how many there are. Even in simple cases, we have seen large fragments there. So I think to answer the question, the role of arthroscopy is not totally established in the literature. We are finding increasing amounts of intra-articular pathology if you do it, and you can address that. I would say it's not a routine accepted or necessary thing to do, but if something is not right, certainly, if you are good at it, you can certainly have a look inside the joint.
So, Professor Panchbavi, before you leave, this is the last case. Male 62, non-diabetic, sustained a fall and had a closed injury. Nimish bhai, how would you manage this patient?
Does he have a tip of fibula fracture? Probably in my mobile, it's not probably seen properly because your
So
window is covering my view.
Yeah, Navin bhai, can you hide the window?
Well,
No,
if it's
it's a small screen, so that is the problem of small screen, nothing else. But I will mark it. I will mark it. Whatever you want to say.
The sort of tip of the fibula is gone. Probably my gut would be to cast him. I don't know.
Okay, so Biloni plaster was given for 6 weeks to this patient, and then patient comes to outdoor, now 10 weeks. Patient is walking, pain is persistent. There is a lot of swelling.
Instability.
What next, Nimish bhai?
Well, an MRI probably to rule out ligamentous injuries, and then
Any stress views done or not?
Stress was not done, but this is the one case in ankle injury that I am always going to get MRI.
Yeah.
And this is where, and then look at this MRI picture, that fragment is not united. At the same time, there is something going wrong here into peroneal. And when I opened, there was an accessory low-lying muscle, Professor Panchbavi here, and which was excised. And then fragment was also excised. And there was a long split tear of peroneus longus. The whole segment I had to excise. And in this case, I did excision of the ununited fragment, repair of the lateral ligaments, excision of the accessory muscle, excision of the peroneus longus, and tenodesis of longus with the brevis. The only thing I did not do was groove deepening. Comments by Professor Panchbavi. You also showed us similar case many years back.
Yes, thank you. You know, the X-rays which you showed, the fragment. You know, can we go back to that X-ray, please? The lateral, the AP X-ray. You know, there are some clues when sometimes, you know, you will see a longitudinal. It's not quite there, but, you know, it has to be a little bit higher, and it's like a sliver, you see. So basically that is a shadow of the sleeve avulsion. See, so, you know, just like the Bankard's phenomena which occurs in the shoulder, it can lift off the piece of bone there. See, so you see a different kind of shadow. This is not quite like that. So I was thinking whether it's a peroneal tendon injury. It probably was, but it did not come out of the groove in this scenario. So if when you repair the peroneal tendons and they go nicely, and if you maneuver the ankle, you know, the provocative maneuvers to kind of try to sublux the peroneal tendons, and if the tendons do not come out, then you certainly don't need to deepen the groove. But if they're easily coming out, then yes, I would do a peroneal deepening groove, you know, because we want to make sure that the peroneal tendon will not come out again. So, you know, so that's the criteria for me to whether to deepen the groove or not. We do the ankle maneuvers intraoperatively to see if that peroneal tendons will easily sublux out or not. And sometimes you see if in a chronic scenario, you can see a false pocket there. So in those scenarios, yes, of course, you have to do a fibular groove deepening. Hope that answers the question.
So 2 points I wanted to brought through this case. This is a kind of a Bankart lesion of the ankle. And these are the cases where you have a small sliver of the fibular fracture. I like to get MRI. And Dr. Girish was asking about the lateral ligament repair with ankle fracture. These are the cases where you have to repair the lateral ligaments of the ankle. And mind you, you could have a peroneal tendon injury here because a long segment of peroneus longus was excised. The groove itself had a less volume. So I did not went in and did the groove deepening procedure. Otherwise, you might require sometimes to go ahead and do the groove deepening procedure. So thank you very much, Professor Panchbavi, for your time. Thank you, Nimesh, for your time. Navin, you've been an excellent organizer. Keep it on. We wanted to discuss on 2 calcaneus fractures also, but maybe this Sunday we have a foot and ankle trauma current concept webinar number 2, where we have Dr. Celine Parekh from US, we have Dr. Karthik Hariharan from UK, Dr. Rajiv Bora from Amritsar, and Dr. Kashyap Adeshna from Junagadh, where we might take up calcaneus, talus, Lisfranc, and fifth metatarsal. So do join us, and thank you very much.
Again at the same time. And I'm thankful to all from Gujarat Orthopedic Association. And tomorrow, probably we have one good non-orthopedic webinar is on fitness, physical and mental fitness during this corona crisis. And on the Saturday, we are having on biological fixation of humerus, where we are having Sergio from Brazil and other faculties. And Sunday, foot and ankle. So please join us on all 3 days. And thank you very much, Dr. Vinod. Dr. Nimish Bhai, thank you. Thank you, sir.
Thank you for listening. Thank you all participants.